Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This presentation is titled Facts on Fibroids, Definitions, Symptoms, and Management Options. And the presenting provider is Trinity Health IHA Medical Group Obstetrician Gynecologist Alia Shah. Dr. Shah sees patients at our Plymouth location as well as our Domino's Farms location in Ann Arbor. Welcome, Dr. Shah.
Thank you. Thanks, Allison, for the intro. And thank you all so much for joining me tonight. I know that it's really hard to find time in everybody's busy summer schedules on this weekday evening. And my goal for everybody really is to leave this presentation feeling more informed about their health and more specifically about fibroids, what they are and how they can be managed. So please let me know if you have any questions. Like Allison said, feel free to type them into the chat and we will try to get to as many as possible near the end of the presentation. So before we get started, I just wanted to tell everybody a little bit about me. So I am a born and raised Michigander, and I did a lot of my studies throughout every university in Southeast Michigan. So I got my bachelor's in Spanish at Wayne State downtown, and then I went to medical school at U of M, where I met my husband, and he's now working as a cardiac electrophysiologist at Michigan. I went to residency at Beaumont Hospital in Royal Oak, and this is a picture of my husband and I at our graduation, or at my graduation from residency. And now I'm going on my third year in practice at IHA OBGYN, and I'm at the Domino's Farms as well as downtown Plymouth locations. And I do surgery both at St. Joe's in Ann Arbor, as well as at the Livonia Medical Center. And I also have privileges at St. Mary's. So we will go ahead and get started into the meat of this presentation. So before we delve in, I really want everybody to understand some basic definitions. Like, what are fibroids, right? So they are benign, non-cancerous growths that develop from the muscular tissue of the uterus. So if this is the lining of the uterus, this is what's called the endometrium. And out here in the wall of the uterus, that's the muscular wall or the smooth muscle of the uterus. And that rapid proliferation is what causes or what gives rise to fibroids. And they are firm, rubbery masses that will grow outside of the uterus. And they're also known as leiomyomas or myomas. And they are actually the most common type of growth that can be found in a woman's pelvis. Actually, 75% of women have fibroids. So while their size, location, and shape can vary greatly, they can really have a lot of different symptoms based on their different sizes, shapes, or locations. So they can be inside the uterus, like I said, they can grow on stem-like structures outside of the uterus, they can be really small, or even grow like 5 to 6 inches wide. Sometimes they can be the size of a golf ball, even a baseball, or some people will have grapefruit sized fibroids. So they can grow so much that they can fill a woman's entire pelvis or even make her uterus grow up to her belly button and fill the entire abdomen as well as the pelvis. So they can be small for a really long time, or they can grow super quickly. They can also grow really slowly over a number of years. So there's a wide variety in the type of fibroid. And as a result, there's a really, really wide variety in the symptoms that they could potentially cause. In some people, fibroids do remain really small, and so they don't cause any symptoms or any problems. But as we'll learn throughout this talk together, they can sometimes cause problems depending on where they are. So the most common symptom that I really see in my office as a result of fibroids is menstrual changes. So women commonly will have longer periods, more frequent periods, or heavier periods. They will have more pain or cramping like during their cycles, and they can even have intermenstrual bleeding or bleeding between their periods. A lot of women will also suffer from anemia or low hemoglobin or blood counts because of chronic blood loss or a lot of blood lost on their very frequent periods. And then this causes them to be feeling other symptoms. So things like lightheadedness, dizziness, even, excessive fatigue. And even in some cases, women may require a blood transfusion because of how heavy the bleeding is from their fibroids. Women may also feel pain outside of menstrual cramping. So, this can be felt as like a dull, heavy ache in your abdomen, your lower back, or even during intercourse. And then, fibroids can have a separate pressure type of symptom, what we commonly refer to as bulk symptoms. And these can make it harder to pee or cause women to be urinating more often. It can also cause constipation, rectal pain, or difficult bowel movements. Women can get an enlarged uterus and as a result, an enlarged abdomen from fibroids and a lot of like distension and bloating. So, if you are feeling any of these symptoms, it is really important for you to talk to your gynecologist. So, I want us to just get a little review of anatomy here so everybody can understand where fibroids can grow to potentially contribute to some of these symptoms, right? So, let me just orient everybody here. So, this is the front of the body. The belly button would be up here. This is a woman's pubic bone. And then this is the bottom here. So, this is the bladder in the front. Here we have the uterus. And then this is the vagina. So, here's the vaginal opening. And then this is the rectum. And here is the anal opening. Okay. So let's imagine if we had a fibroid that was growing right here. Okay. This would be pushing into the bladder. So that could be what's causing a woman to urinate more often or make it even harder for her to urinate. Sometimes if it's down here and potentially blocking the urethra, the opening. So, a lot of different bladder or urinary symptoms. On the flip side, back here, we could have a fibroid growing in this area. And that, as you can imagine, can make it more difficult for stool to move through the rectum and be evacuated, causing women to have constipation. Or they can have a fibroid down here, and that can make it so that they have rectal pain because it's sitting on nerves or things that are associated with the rectum. So, a lot of different symptoms that I want everybody to understand because of the location of the uterus in relation to your bladder and your rectum in your pelvis. So, many women will ask me about fibroids and the potential impact on fertility. And there is an impact on fertility with fibroids. Women can have, unfortunately, an increased risk of miscarriage, possibly with fibroids. They can have a harder time conceiving or even infertility. And it is important to understand that while fibroids may cause infertility, other causes of infertility are actually more common and we should be exploring other factors before we deem fibroids to be the number one cause of a woman's infertility. It is true that 5 to 10% of infertile women will have a fibroid, one or more, right? But only in 1 to 2.5% of cases of infertile women is fibroids the sole cause of their infertility and no other causes are found. So when fibroids are thought to be a cause, many women are able to get pregnant after they are treated. And we will go through the management options in this talk as well. So, fibroids can also increase the risk of needing a C section, cause more bleeding than normal during a delivery, and that can be a vaginal delivery or a C section. And they can also affect a baby's growth or the position of your baby, whether it's head down, butt down, sideways during a pregnancy. Many women who have fibroids are getting serial growth ultrasounds throughout the pregnancy to monitor some of these risks. So, how do we actually diagnose fibroids, right? How do you know if you have something like this? They can be diagnosed or found via a routine pelvic exam, just when you're going in for your annual checkup. They can be found via diagnostic tests like an ultrasound, which is the most common modality utilized to find fibroids. They can be diagnosed via an MRI, a saline sonogram, which is right here. And that's where we actually put water inside of the uterus to see the whole cavity. So you'll see this is a normal SIS or saline sonogram, and there is nothing inside of this uterine cavity. This endometrium is totally clean, okay? And this is where we have an abnormal saline sonogram identifying a fibroid here in this woman's cavity. And that could be something that could impact her future fertility, her risk of miscarriages, or symptoms that we talked about, like heavy bleeding, anemia, things along those lines. Fibroids can also be diagnosed with a test called a hysterosalpingogram, and that's where we are putting in dye through the uterus to check on the opening of women's fallopian tubes. And it also, similarly to a saline sonogram, will outline a little bit the uterine cavity. So sometimes we can see if there's a defect in there. Fibroids can also be diagnosed via hysteroscopy, which can be done in the office or in the OR. And we'll talk more about that. That's where we are using a small camera, guiding it through the vagina and into the uterus to actually see inside the uterus, not with an MRI or an ultrasound, but just straight up with a camera. And then, of course, some women get CT scans for other reasons, and a fibroid can be seen. A lot of these tests will be women like having these tests for, like I said, other reason, maybe kidney stone, gallstone, something, and then a fibroid is incidentally found on their uterus. So many women then will ask, well, how did I get these fibroids and why did I get them? And that is really unclear, unfortunately. And we need to do more studies to understand why some women are developing fibroids and some are not. There are some associations that have been found, though. So let's go through those. We know that fibroids do run in families. Okay. So if your mom has them, yes, then you may be more likely to get a fibroid. They are associated with race, and Black women are more likely to get fibroids and have more severe symptoms of fibroids than white women. And one thing we know about fibroids is that estrogen and progesterone hormones really appear to be involved in the growth of fibroids. So, levels of estrogen and progesterone can increase or decrease throughout your lifetime. So, an example is in menopause. Menopause causes a decrease in estrogen, and fibroids do often shrink when women enter menopause. On the flip side, obesity or being overweight actually can cause you to have increased estrogen because fat cells can produce estrogen. So that could potentially cause fibroids to be growing. Getting your period at a younger age, meaning you have a longer lifetime exposure to estrogen, can increase your risk of fibroids, or going into menopause at a later age can also increase your risk. So, fibroids are most common in women ages 30 to 40, so kind of middle age, but they really can occur at any age. Okay. So, now that we know, what fibroids are, what their symptoms are, what are the potential causes or links or associations, we can move on to what do I do about them now that I know that I have them? And this really is driven by your symptoms, right? So if you don't have any symptoms from a possible incidental fibroid found on a CAT scan, you may not need to do anything besides observation. And when I'm thinking about my management options for women with fibroids, and the things that we will discuss are really three broad categories. Okay. So the first one is I briefly mentioned observation. And then the second is medical management. And I classify that into non hormonal management and hormonal management. And then we have surgical management, and that can be minor surgeries or major surgeries. So now let's go through each of these in more detail. So, first we have observation. Okay. We also call this like watchful waiting. And this, as I mentioned, is for fibroids that are not causing symptoms, fibroids that are small, and possibly for fibroids that are occurring in women who are nearing menopause. These are people who often don't require treatment, right? Because bleeding can stop and fibroids can decrease in size potentially after menopause. So, some women in their late 40s may choose to do watchful waiting or potentially less invasive management options that we'll talk about in future slides. Watchful waiting or observation is really not for women who have the following symptoms. Okay. So if you have heavy or painful menses that are causing anemia, that are disrupting your normal quality of life, this is not something that you need to live with. And we have management options that we can discuss. So bleeding between your periods that's bothersome, a rapid increase in growth of a fibroid should be managed, or a lot of bloating or swelling. If, of course, you have infertility and you desire to conceive, and if you're having pelvic pain. So these are all things that would potentially move us towards the medical management category or the surgical management category. So let's get into those. So when we discuss medical management, we can start with talking about natural remedies. I will caveat this, okay? There are small studies that show possible dietary and environmental factors that can influence fibroid development. But this data is unfortunately weak, and we do need to do more studies to understand the links for further natural remedies that could hopefully have more of a benefit on fibroids. But I'll go through what I have found some studies for, even if the evidence is potentially weak, right? So consuming a nutritious diet and healthy exercise routine is important for fibroid management, especially given its association with obesity. And specific studies showed that actually green vegetables and fruit in your diet were more helpful for fibroid management and symptom management than other foods. Okay. So, vitamin A and vitamin D supplementation, and it hasn't been shown the exact amount of vitamin A or vitamin D that is best for fibroids, but it can help to manage some of women's symptoms and potentially shrink fibroids as well or prevent them from growing. And then acupuncture, interestingly enough, there is some evidence that it can help relieve pain, improve hormone production, and reduce inflammation throughout your body and subsequently within your uterus and as we're managing fibroids. So uh, overall, what we want to take away from these natural remedies too is avoiding things like red meat, beef, dairy, soy products, and BPA exposure. There are actually studies that are showing that women who have a consumption or association with some of these things have an increased risk or increased growth of fibroids that may already be present. Women who consume a diet that has a high glycemic index or have alcohol consumption, and specifically the association was with beer, that can also increase their fibroid risk. Outside of natural remedies, we can talk about other non hormonal options that are available, some over the counter and some prescription. So, the majority of non hormonal options are really being utilized for women who have heavy bleeding and really painful periods. But these options that I'm going to discuss may not affect the actual growth of the fibroids or the bulk symptoms if you have those. Okay. So, anti-inflammatory medications like ibuprofen, Motrin, Aleve, naproxen, these things can all be found over the counter and in cyclic high doses around your cycle can help to decrease pain and heaviness associated with your period. Another option that's non-hormonal, but it is prescription, is something called tranexamic acid. The other name for it is Listida. We, within the past 5 to 10 years, started to use this pill medication for heavy bleeding associated with fibroids. And it's been working really well. It does not interact with hormones, but instead, it actually works on clotting factors in your body to decrease the amount of bleeding that you're having. So while it reduces the blood loss during a period, it doesn't totally stop the period. Okay. And this is just an example of what like a tranexamic acid RX will look like or prescription. And then we'll talk about medical management into hormonal options. So, this is probably the most common management option that many women will utilize first line for fibroids. Okay. And birth control pills are really first line. And there are many different types of pills, some with estrogen, some without, and only having progesterone that can be utilized for fibroids. And these are also often used to control heavy bleeding and painful periods, but not necessarily shrink the fibroid. Okay. So then we have gonadotropin releasing hormone agonists. I know that's a mouthful. So we just tend to say GnRH agonists. And you may have heard of this. The other name for it is depolupron or leuprolide acetate. And this is a medication that can not only stop your bleeding, decrease your bleeding, but it can actually shrink fibroids. And this has been proven, and I have seen this in patients. This is a medication, though, that does have a lot of side effects, unfortunately. And some of the side effects include bone loss or an increased risk of osteoporosis, vaginal dryness, some night sweats, menopausal type symptoms. However, taking low dose estrogen or progesterone pills can actually help to reduce these side effects. So, when we are using this low dose estrogen or progesterone pills, which is called add back therapy, we can extend the use of a GnRH agonist to 12 months rather than 6 months, which is the typical recommended use if you don't have add back therapy because of the risk of osteoporosis. So, after a woman unfortunately stops taking a GnRH agonist, her fibroids do usually return to their previous size. We don't know how long they'll take, and that varies from person to person, but it will cause a shrinkage. And then people will say, well, why would I use this at all then if it's so temporary? And there's so many reasons why a woman may use this, right? If a woman has a really big uterus and she wants to control some of her symptoms in this immediate time frame, but isn't ready to move towards something like surgery or something more invasive quite yet, this is a great option that we can use now with add back therapy to help control a woman's symptoms, decrease or shrink the fibroids, and hopefully make her feel better until, something further potentially needs to be done. And then GnRH antagonists are another option. And these are pills. I'm sorry, I forgot to mention that GnRH agonists are actually given as an injection or intramuscular formation. But GnRH antagonists are pill form, and they have hormonal add back therapy already included in the pill. And you can use these because they have add back therapy included for up to 2 years. This is a newer sort of medication that has been utilized as well within the past 5 to 10 years and has had really good effects for patients. Another name for this is called Relugolix, or the brand name is Myfimbri. You may have seen commercials about that. And so these are can be used to treat heavy bleeding for up to 2 years, but because it has the ADVAC therapy included in every single dose, they don't always shrink fibroids. The ADVAC therapy can reduce those side effects, though, of osteoporosis, bone loss, hot flashes, night sweats. And it is really this medication is decreasing anemia and sometimes some bulk or pressure symptoms while preserving a woman's bone mineral density. It is, or it can sometimes be difficult to get insurance coverage for Myfimbri before we try other options that I discussed or other prescription options. And then another popular option for fibroids is the hormonal IUD or intrauterine device. The one that we most commonly use for fibroids, because there's so many IUDs, is a Mirena IUD, and this is a progesterone or progestin only IUD. And I have a little picture here to show everybody what this looks like, right? So this is the uterus that we talked about earlier. This is the endometrium or the lining of the uterus, and we insert or an IUD here, and this secretes progesterone in a woman's uterus and into the muscular layer of the uterus. And the hope is that this will prevent the growth of further fibroids. And as it's sitting here in the endometrium and secreting progesterone, it can really decrease a woman's bleeding pattern. And some women even stop their bleeding altogether. It is important to know, though, that this option is for women who have fibroids that are not distorting the inside of the uterus. So, if you had a fibroid that was going like this, it would be difficult to insert an IUD, and it's not always recommended in those cases. They may need to somehow remove this with a surgical option that we'll discuss, and then an IUD could go in to prevent these fibroids from growing again in the future. So IUDs are great because they reduce heavy and painful bleeding that is associated with fibroids, although it may not necessarily treat the actual fibroid itself, right? So this is for symptom management, although it can prevent further growth. So, okay, let's move now into surgical management. And surgical management is for sure for pain and pressure symptoms from fibroids, but it's also for women whom medications aren't helping their heavy or painful periods, or really if they, desire something more so than medical management. And surgery is really going to depend on the size of your fibroids, how many fibroids you have, where your fibroids are. Surgery depends on your personal goals. What are your plans for pregnancy and your even feelings about surgery? And also, of course, on your personal health, right? So, I just included a couple of pictures here depicting some surgical options. So, this is an open surgery or what's called a laparotomy. And not all surgery these days needs to be done via a laparotomy. And that's important to understand, right? We have a lot of minimally invasive surgery options to manage fibroids these days, for which women can recover much easier than this type of open surgery. And many women go home, the majority go home the same day for many of the surgeries that I'll discuss, aside from this one. So, this can be a cut similar to a C-section in your lower abdomen or pelvis, or it can go vertically from like the belly button downwards. And that's an open surgery. And that can be a myomectomy, which is removal of a fibroid. And we'll talk about that, or a hysterectomy, which is removal of the uterus. And then this is a minimally invasive surgery. So, this is depicting a laparoscopic surgery on a woman's abdomen. And this is where we're using mini, like 5 to 10 millimeter incisions across a woman's abdomen, either 3 to 5 different port sites, and inserting instruments through those ports to either remove a fibroid or remove a uterus. And so this can be done, as I mentioned, laparoscopically or robotically, and that really depends on a multitude of factors, including like the size, number, and location. So whether you do laparoscopic or robotic. So, as we are talking about surgical management, we'll go from least invasive to most. And one of the options is a myomectomy. So, myomectomy, remember the other name for fibroid was myoma. So, ectomy is just removal of myoma or removal of fibroid. And this can be done via multiple approaches. So, there's three main ways that we do myomectomies, and this is via a hysteroscope, which, as I mentioned way earlier, was when we put a camera in the vagina and then into the uterus. And I'll show you actually what that looks like here. So, let's get oriented again. This is the bottom. This is the rectum. This is the uterus. Here is the vagina. And here is a woman's bladder. So this up here would be her belly button. And so, generally, if we're doing a hysteroscope with a myomectomy, also called a hysteroscopic myomectomy, we would do this in the operating room. And this is where we're inserting this video camera through the vagina into the uterus. And then, oh, we see this fibroid right here in this woman's uterus, and we can insert what's called a resectoscope device, or it's really a fancy name for a little shaver device that goes through this camera into the uterus, and we can shave down this whole fibroid. So, for a hysteroscopy, it is destroying fibroids that are in the lining of the uterus, but it doesn't necessarily have an impact on fibroids that are deep in the muscular wall, like this muscular wall portion of the uterus. But it can often control a lot of the bleeding and pain even that fibroids such as these are causing in a woman's cavity or on a woman herself. And in most cases, like I said, women are going home the same day. This is a 30-minute or so procedure. And then laparoscopic or robotic myomectomies can be done. I showed you what those looked like on the prior slide. Same with an open incision. And then other options are something called laparoscopic radiofrequency ablation. I am just trying to advance my slides here. So laparoscopic radiofrequency ablation is a newer procedure within the past 5 to 10 years that can also be used to help manage fibroids and their symptoms. And this is a procedure that uses energy and heat to shrink the size of fibroids. And we're using, like I said, laparoscopy, and we're using an ultrasound probe to see the fibroids, the camera, and then this here is a device that has needles that deploy into a fibroid. And then those needles are what heat up and then end up just destroying the fibroid tissue through heat energy. So more research is, and that's what's depicted in this corner picture. So we do need more research on understanding the effect of radiofrequency ablation on future pregnancies for women who have had this procedure. So it may not be the best option for women who desire future fertility, but it is a great option that is uterine sparing for certain types of fibroids that have a characteristic location and can really manage women's bulk symptoms or those pressure, like urinary constipation type symptoms. So, uterine artery embolization, another great minimally invasive option for managing fibroids. And this procedure is actually not done with gynecologists. It is a referral that I place for, or that gynecologists will place for interventional radiology. And with this, they are utilizing a small incision near the groin, going up through the artery here in the groin, putting a catheter, and then deploying small, tiny sand-like particles into the arteries or blood vessels that are feeding fibroids or that are feeding the uterus. And in doing so, when you kind of cut off that blood supply to the fibroid with these small sand-like particles, you can then shrink the fibroid because its blood supply has been cut off. So this causes a significant reduction in uterine size and in fibroid volume, and multiple studies have shown that. And it's often done as an outpatient procedure too. And then hysterectomy. So, hysterectomy is removal of the uterus, and the ovaries may or may not be removed. And hysterectomy is done, when treatments have not worked or it's not possible to do some of the other treatments because fibroids are so large or potentially for other reasons. And it's important to know, right? Hysterectomy, you're no longer able to have children after a hysterectomy, and the uterus is removed through either a cut in the abdomen like I talked about with an open incision, or laparoscopically or robotically with mini incisions. And then we can also remove it vaginally through like a vaginal hysterectomy. Most women are going home the same day after a hysterectomy. And as I mentioned, this is the only permanent option for fibroid removal because sometimes when a woman has one of these other surgeries to manage their fibroids do often grow back in some period of time. It's unclear exactly how long that is for each person. That's different. Okay. Ideally, we're trying to get years, right? But that's not always possible. And so, uh, fibroids in the United States are actually the number one reason for a hysterectomy, which I thought was just fascinating. So, that really brings me towards the end of my talk. So I hope that everybody feels a bit more informed about fibroids, what fibroids are, and how we can manage them. And really, because everybody has different goals, and what's best for one patient may not be what's best for another patient, I or your OBGYN can help to create individualized treatment plans to help manage your fibroids and the symptoms that they're causing. And with that, we'll go ahead and take any questions.
Okay, thank you, Dr. Shah. So again, if you'd like to ask a question, you can drop it into the Q&A feature, which again is at the bottom of your Zoom screen. You can drop it in at any point. We have a handful in there, so I will just get started. So the first one, have you seen fibroids cause GI symptoms like rectal bleeding or GI inflammation or blockage?
They can cause inflammation. It has been shown that fibroids are associated with inflammation. And I have not seen it where they're causing rectal um, complete blockage, but they can cause rectal bleeding in that sometimes women will get so constipated from fibroids that they then in turn will develop hemorrhoids. And this can then subsequently cause rectal bleeding.
Okay, so that's something that you could ask your OB-GYN
Definitely.
at your next point. Okay. Okay, so this person is currently on the Lupron shot, depot shot. She has a baseball-sized fibroid. So she wants to give it about 6 months, it looks like, and she just took number 3. So the question is, what should the next step be if the fibroid doesn't shrink on this treatment?
Yeah, no, that's a great question, right? What happens if with Depo-Lupron, we don't have shrinkage of fibroids? And it, that's really something to discuss in your specific case, right? Like with your OBGYN, but you could potentially utilize any of the management options that I discussed that were subsequent to that. So whether you're going to use Myfimbry next, or that was the oral pill medication that had add-back therapy added, or could potentially move towards surgical management options, depending on where that fibroid is.
Okay. Um, so this person is asking about, and I'm sorry, it's BC? Is that one of the treatment options? Does that sound right, Dr. Shah?
Yeah, I believe that they most likely mean birth control.
Okay, perfect. So they're asking if birth control long term is harmful to hormone balance, increases risk of blood clots. She's wondering, why is it prescribed for so many things, including fibroids?
Yeah. So there is no evidence that birth control is disrupting the balance of your hormones. It is actually giving you steady state low dose hormone. The majority of birth control is doing that. Okay. And when women come off of birth control, their hormones typically resume function in terms of how they were doing it before. And can you repeat the second part of the question? I believe it was about blood clots in
Yeah,
association with birth control pills.
yeah,
And
exactly.
some birth control pills, not all, do have an association or a risk of blood clots. That risk increases as women get older. And the majority of women don't have predisposing factors that would increase their risk of developing a blood clot on birth control pills. There are many side effects to different medications, and we're trying to balance some of those, right, based on women's personal health as we discuss which of those options is going to be best for their treatment plan.
Okay. If surgery is your only option, is there a recommendation for someone who is obese with the fear of a potential infection?
Yeah, that's a really good question because surgery comes with risks, right? And so it depends on multiple factors. And so obesity could potentially increase your risk of infection with surgery. But as I mentioned, we do have a lot of minimally invasive options these days. And so there have been multiple studies that have shown a decreased infection rate, even in obese patients with minimally invasive surgery. And one of the benefits of the robot procedure, whether it's robotic myomectomy or robotic hysterectomy, is that it has allowed us to utilize technology that is allowing us to perform procedures or surgeries on women that have higher weight or higher BMIs.
Okay. And if you're someone who is either prone to infection or for some reason is more cautious of them, is that something you can bring up to your doctor beforehand?
Definitely. I would highly encourage all of you to bring your concerns up to your physician. If you have, things from your past, like medical conditions, or knowing that you yourself are more prone to infections or more prone to bleeding after a prior surgery, all things that you should definitely bring up with your physician.
Okay. So if someone had a myomectomy, what is the best way to know if your fibroids have returned?
Excellent question. That is a really good one. And a lot of people will ask me that, like, should we be doing serial ultrasounds after I had a myomectomy? And really, there is no clear data about whether or not we should be doing multiple imaging after a woman has had a management option, okay, or a surgery. And so the best way, in my personal opinion, and I would say a lot of OBGYNs practice this way to know is based on your symptoms. So did you have return of some of the symptoms that you were experiencing previously, even in a small way, right? So it may not be major, but that is definitely a way in which we can tell whether or not your fibroids have returned.
Okay, I was wondering this while you were speaking. Should I ask my OB-GYN to check for fibroids even if I don't have symptoms?
So that is something that's personal preference, right? But the majority of OBGYNs would say no. And the reason being is what would you do about it, right? Like if you knew that you had a fibroid, it wasn't causing any symptoms, there's really nothing that to do unless, of course, if you're trying to get pregnant and you're having difficulty conceiving, that's a totally different story and kind of puts us down a different trajectory. And we would definitely check for fibroids in that case. And one of the things to say is that we are actually, as OBGYNs, screening for fibroids at every single annual exam during our pelvic exam. And so majority of times, if a woman has a fibroid and she doesn't know it, and we potentially feel something, we will definitely alert you to that. And that is one common way. But again, what's the management plan there if that woman didn't even know she had it and doesn't have any symptoms from it?
That's such a good reminder too that your physician has so many things going through their mind while they're examining you that you don't, as a patient, always realize how many things that you as a physician are really paying attention to throughout the examination. So it's a really good reminder of that.
Definitely. And there are two components to a pelvic exam, right? It's not just your routine pap smear where we're using a speculum or that metal device to look inside and see the cervix and collect some brushes or specimens. The second component of a pelvic exam is what's called a bimanual exam, where we are utilizing two fingers inside of the vagina and a hand on top of the abdomen. And what we're doing in that time is feeling the uterus, the cervix, the ovaries, the tubes, and really the entire pelvic area to determine, is there a mass or a growth that's here that shouldn't be here?
Hey, that's so interesting. Okay. Can a fibroid be removed during a delivery?
Excellent question. So I'm not sure if you were referring to a vaginal delivery or a C-section, but if we're talking about a vaginal delivery, I would have to say no. And during a C-section, it is actually the preference to not remove a fibroid during a C-section. So let me talk you through why that's the case, because a lot of women may be like, why not? You're already in there. And the reason is I talked about how fibroids are hormonally mediated, right? So estrogen and progesterone cause fibroids to grow. And so often we see that fibroids will grow in pregnancy. And then postpartum, when a woman is no longer pregnant, those fibroids will subsequently shrink back to their normal size. Bigger fibroids means more blood loss, increased risk for hemorrhage. So if we are doing a C-section, we already have a risk for blood loss, right? And so doing a myomectomy or removing the fibroid at the time of the C-section significantly increases your risk for hemorrhage because the uterus has so much blood volume going towards it when a woman is pregnant. So it is really not recommended by any means to remove a fibroid at the time of a C-section, unless in the rare case that fibroid is in the way of getting to the baby or of delivery.
Okay. If fibroids are giving you issues, do you have to go through all the steps or can you go straight to a hysterectomy?
That's also an excellent question and something I would encourage you to talk about with, your physician, but I would say that you don't have to go through all of the steps, right? As I mentioned, everybody's goals are different. Everyone's feelings about surgery are different, their medical health is different. So one woman may want to move straight towards a hysterectomy, while somebody else may want to discuss or dive into uterine sparing options. And that is okay. What's best for one person may not be best for another. So if somebody wanted to say, I can't deal with this anymore, I don't want to talk about all these other things, I'm totally fine with that. And I think a lot of OBGYNs would be.
Okay. Can a fibroid move an IUD?
Yes, that is a great question. And they can move an IUD. The majority of times, when an IUD is already present inside of the uterus, it is preventing the growth of fibroids to be inside the lining of the uterus because it's secreting that progesterone hormone in the uterus, preventing further growth when it's secreting low lying progesterone inside. So, the majority of times, we don't see that.
Okay. Um, can you talk about what is considered a heavy period?
Yes, thank you so much for that question. And I'm sorry I didn't include that earlier. So, a lot of women will discuss, I have heavy periods. And of course, everybody's symptoms are subjective. I'll say that right off the bat. But medically, what we define as a heavy period is where you are changing a pad or a tampon, like you're saturating a pad or a tampon every 1 to 2 hours, consistently or consecutively for multiple hours in a row. So, for 2 to 3 hours in a row you're soaking through a pad or a tampon. That really is a heavy period. That's not normal. And that is something that I would advise you to discuss with your gynecologist.
Okay, and if that's not typical for you, is that typically a sign that something else is going on, like a fibroid or something is happening, and you should request an appointment sooner than later? Like, not wait till your annual exam.
Yes, I would highly encourage that if this is something that has suddenly started to occur where you're having an increase in bleeding during your period or even outside of your period, I wouldn't wait to bring that up to your physician and I would schedule an appointment to discuss these concerns sooner.
Okay. Are there side effects for any of the medications that reduce bleeding? And how long should a person utilize this kind of medication?
Great question. So, yes, there are side effects for medications that can reduce bleeding. So, we talked about a couple of options, right? Non hormonal and hormonal options. And each of those have their own risk benefit profile and their own side effect profile. I did mention the side effects specifically associated with GnRH antagonists or GnRH agonists with depo because they are pretty intense. And so, that is the reason why I mentioned those ones specifically. But other medications do have side effects. So sometimes NSAIDs or anti-inflammatory agents like Motrin, ibuprofen, those can cause some GI upset, sometimes nausea, sometimes reflux. Tranexamic acid, really, I haven't found any of my patients having side effects from. And then birth control pills, different pills can have different side effects. Sometimes a woman may have nausea, may have mood changes, and the majority of these will resolve after being on the pill for a few weeks. And then same with the myfimbry option. That one doesn't tend to have side effects that are lasting after the first few weeks on the medication.
Hmm. Can fibroids go away on their own?
It is very rare for fibroids to go away on their own. It's rare, but it is possible. And sometimes we will see this when women enter menopause, when fibroids may shrink. And it really depends on the starting size of the fibroid, right? If a woman has a 5 to 6 centimeter fibroid, it is highly unlikely that that fibroid is going to go away on its own. Highly unlikely, probably 99% of cases it won't. And more often it will grow. But as I mentioned way at the beginning of my talk, we don't know whether it will grow rapidly or whether it will grow slowly over a multitude of years. So I encourage women as you are considering your management options, kind of thinking about the average age of menopause, which is 51, when you will have cessation of hormones that could potentially be driving growth of your uterus or of your fibroids, sorry. So that younger women may want to be more aggressive with management about their fibroids, whereas women who are in maybe their later 40s may not necessarily be so aggressive if those symptoms are not bothersome, right? Of course, if the symptoms are frustrating and bothering you, then we got to discuss like more definitive management options.
Okay. Is there a connection between fibroids and PCOS?
Excellent question. So there has not been found to be a connection between fibroids and PCOS, specifically them running in like a patient having both of those that I know of.
Okay. So if you have already confirmed that you have fibroids, are there any characteristics that would help differentiate whether abdominal swelling and bloating is due to fibroid growth or other reasons?
Yes, that's a great question too. So it really is going to depend on your physical exam because, as I mentioned, not only the pelvic exam in that case, but the abdominal exam as well will be an important component to determine, is this bloating or swelling being caused by an actual mass that I'm feeling, or is this something else?
Okay. Do you have to delay pregnancy or postpone getting pregnant for a period of time after you have a fibroid removed?
Yeah, also a great question. And that really depends on whether or not you have to delay pregnancy after you have a fibroid removed, really depends on the type of myomectomy that you may have. And one thing that I didn't mention is if you have a robotic, laparoscopic, or open myomectomy, that may require, and you do desire future fertility, that may require you to potentially have a C section in the future. It just depends on the type of myomectomy that's done and the location of the fibroid. Hysteroscopic myomectomies, you don't generally have to wait more than one period in order to try to conceive. But for some of the other three, there is a waiting time that will depend on which one of those three that you had.
Okay. Any correlation between fibroids and IBS?
Also, a really good question. And I don't know of any. And as I was preparing for this talk, I didn't read about any or find any association with fibroids and women who have IBS.
Okay. Um, have you seen hormonal weight loss impact fibroids or menstrual bleeding?
Have I seen hormonal weight loss impact fibroids? So
So,
the
like,
answer,
the example would be Wegovy. I'm not sure if I'm saying that correctly.
yeah, yeah, for sure. So that is a really good question too, especially as that is something that's becoming more and more popular to utilize as a weight loss option. And so we have seen that with weight loss, women will have an improvement in their bleeding pattern. So that has been shown. It may not shrink fibroids, but it can actually improve your symptoms subsequently from fibroids and prevent their further growth because fibroids are thought to be hormonally mediated. So those medications can actually improve your bleeding pattern and improve cycle regulation.
Okay. So, if a woman has endometriosis and fibroids that are growing, what type of treatment or surgery do you recommend? Because some doctors have not recommended surgery because it can aggravate the cramping and pain symptoms.
So if you have endometriosis and fibroids and your physician isn't recommending surgery because it could aggravate pain or cramping, I would encourage you to discuss, delve into that a little bit further with your physician. And often if a patient is having, if we're, not potentially agreeing on something, I think it's very reasonable to seek a second opinion and ask what other people may potentially think. Because that is really on an individualized case by case basis if you have multiple conditions that are potentially influencing your symptoms.
Okay. So, if you have endometriosis and you have fibroids, it doesn't necessarily mean there's nothing you can do. You should really have an individual conversation with your OB-GYN.
Absolutely, absolutely. There are multiple management options for endo and multiple management options for fibroids, and sometimes those options overlap and both medically and surgically. So that doesn't mean absolutely that there's nothing that can be done. There are definitely things that can be done, and I would encourage you to discuss that with your physician.
Okay. If you have different types of fibroids, is there an option that really works best for multiple types?
That is a great question and really depends on the specific type of fibroid that you have. And so it also depends on which type is causing which symptom or what symptoms you have. If you only have heavy menstrual bleeding, then we may only go for the fibroids or discuss um, being aggressive about removing the fibroids that are just within the lining of the uterus via one of those smaller outpatient procedures like a hysteroscopy with the camera inside of the uterus. But if you are having heavy bleeding, and you're having a lot of those bulk symptoms that I talked about, like constipation, urinary frequency, urgency, or difficulty urinating, then we'll potentially have to talk about a different management option or a different surgical option.
Okay. So this person's mother is postmenopausal and still had fibroids. She ended up with a hysterectomy. Is it common for fibroids to stick around after menopause? And do you recommend an ultrasound annually during the watchful waiting period?
That's a really good question, too. So, thank you for that question because that is something, whether or not uh, annual ultrasounds are recommended based is annually for women with fibroids, that is something that is not clear by the American College of OBGYN. And so, sorry, I had included my references on one of the slides, but the American College of OBGYN is the OBGYN governing body in the United States and where we get a lot of our recommendations for management options. And there is no clear consensus on should we be doing ultrasounds every 3 months, every 6 months, every year, every other year for women who are postmenopausal or even premenopausal who are having fibroids. And in my practice, it depends on really the size of the fibroid in menopause and whether or not it's causing symptoms, whether we get a yearly ultrasound or not. And I would say that the majority of physicians will use shared decision making with their patient to determine whether or not that's best for them. Um, the first part of that question was the patient's mother was menopausal and it sounded like still had fibroids even in menopause. And that is also common. We don't always see that fibroids shrink in menopause, but it is more rare that they will actually grow in menopause. They generally will tend to stay the same size.
Okay. Are fibroids common after fallopian tube removal?
That's a good question, too. And removal of the fallopian tubes actually does not affect the growth of fibroids because most commonly, as I said at the very beginning, fibroids arise from the smooth muscle or muscular wall of the uterus. And so the fallopian tubes are totally separate from that muscular wall. And unless the uterus itself is removed, then yes, just fallopian tube removal will not affect the growth of future fibroids.
Okay. Will fibroids decrease in size after delivery? So I'm assuming after delivering a baby.
Mhm. The majority of times, so the majority of time, fibroids that have grown during a pregnancy will shrink post delivery. That is the majority of times the case, yes.
Okay. So this person just had surgery to remove a cyst on the ovary and also has fibroids in the uterus. They
Mhm.
want to have children, so they're in that watchful waiting period, even though they went in to remove the cyst. Is that typical to remove a cyst but leave a fibroid?
That's yes, excellent scenario. So sometimes we will remove a cyst and leave a fibroid because it depends on where the actual fibroid is located, right? So if it is not located anywhere near the endometrium or that lining of the uterus, then I'm just going to go back here. So
Sure.
we can look together and see. So, if the fibroid is not located or affecting the lining of this uterus and it's out here, or potentially, I had shown a slide at the beginning, potentially a fibroid over here, or here, or here. These are fibroids that are highly unlikely to impact your fertility or your ability to get pregnant or impact your pregnancy. And so it is common that those fibroids would be left alone during a laparoscopy procedure or some type of procedure to remove an ovarian cyst because myomectomies or fibroid removals are associated with a really high blood loss, whether they're done robotically, laparoscopically, or open. And so that's one of the reasons why, if they're small, they're not causing symptoms, and you do desire future fertility, they're often left alone.
Okay. Can fibroids create urinary blockage? And, oh, I'm sorry. Can fibroids that create urinary blockage also cause leg edema?
It is possible for fibroids to cause leg edema, separate even from symptoms contributing to urinary blockage. And that is because fibroids can grow in certain cases that can be impacting women's blood vessels or lymphatic return, or even like certain nerves. And that's why it can contribute to pain in certain cases too, like pain that radiates down the leg, even.
Okay. Can you tell from imaging alone if a mass is cancerous?
Great question. So the question was, can we tell from imaging alone if a mass is cancerous? And fibroids, over 99% of fibroids are benign, and they have a very characteristic appearance on ultrasound and on MRI. And so there are features that are more concerning for cancer on ultrasound and MRI that do point more towards a cancerous cause rather than just a typical benign non-cancerous fibroid. And if a physician was concerned for something like that, they would definitely, majority of time, consult with a gynecologist, oncologist to review the images and discuss a treatment plan moving forward.
Okay. Are there symptoms after a hysterectomy? So I'm not 100% sure what that means. Um, but I would imagine, would your symptoms go away once you have the hysterectomy in terms of fibroid symptoms?
If your fibroids are growing in your uterus, and sometimes they can grow outside of the uterus in some of the other uterine tissue called the broad ligament, etc. So if your fibroids are growing inside of your uterus, then yes, your fibroid symptoms should go away with removal of the uterus or removal of the fibroids.
Okay. So this person is in their 50s and still has their period, does not want children. Is a myomectomy advised?
That's a really good question. When women are nearing menopause and do not desire future fertility, it's a case by case basis again, and I would encourage you to discuss that with your OBGYN, whether a myomectomy or a hysterectomy is advised. But I will say that myomectomies are associated with an increased risk of blood loss over a hysterectomy and also an increased risk of potential scar tissue. And so sometimes if a myomectomy doesn't potentially relieve all of a woman's symptoms, then we have to resort to a hysterectomy, and that can be even more difficult to do or to perform after a myomectomy has already been done because of scar tissue that may have developed. So that is one of the reasons why some women will, after understanding the risks and the benefits, move towards a hysterectomy, especially if they're nearing menopause or if they don't desire future fertility.
Mm.
And I will say one other thing is that there's always the risk that fibroids can grow back, right? So if you leave the uterus in place, fibroids could potentially grow. And it varies person to person whether they are growing really slowly over multiple years or whether they're growing to a grapefruit size within the course of a year.
Okay. Is there a correlation between fibroids and multiple sclerosis?
Great question. I didn't also not come across a correlation between fibroids and multiple sclerosis in my research for this talk, and I haven't heard about that throughout my studies either.
Okay. I'm trying to see if I think we might be at the end of our questions. I'm just looking to make sure I caught everything. This one is asking, okay, why do you discourage I'm going to say this wrong, hysteroscopy for a person post-open myomectomy and with heavy bleeding?
So the question is, why do we discourage hysteroscopic myomectomy after a woman has already had an open myomectomy, correct?
I believe so, yes.
Yeah. And that really, I would depends on the size and the type of fibroid. And, I don't know your specific case, but I would definitely encourage you to ask your physician if they are not encouraging hysteroscopic myomectomy. Why? Why is that? Is it because of the size of my fibroid or because of the location? Asking further clarification questions is never something that I don't want patients to do. I want patients to understand everything because it's your body and ultimately, you have to make a big decision about whether or not you want to proceed towards surgery and what type of surgery. And, we got to do something to manage symptoms. So I think for sure that is something that I would discuss further with your physician.
Okay. All right. I think we covered all of the questions. So thank you. You guys asked a lot of really amazing questions.
Much.
Yes, definitely. And Dr. Shaw, you did a great job of answering. There's so much detail in this. I learned so much about myself, and so I'm super grateful. And I appreciate you taking the time to speak to our community of women tonight. Um, Again, you'll receive an email. It will have all of the information on how to contact Dr. Shaw, where you can schedule an appointment with her, and also where we have other OB-GYN practices in case maybe you're not in either the Plymouth or Ann Arbor area. So look for that to arrive as well. And you are taking new patients, Dr. Shah.
Mhm.
Reply to that email. And again, we're so grateful for your time and your effort to put together all this information tonight, Dr. Shaw.
Yeah, thank
Thank
you
you
so
so
much
much.
for having me, Allison. And thank you everybody for coming out. I appreciate it. And definitely looking forward to having more discussions about this and other gynecological issues in the future.
Excellent. Thank you so much. Have a good evening, everyone.
You too. Bye bye. Thanks.